medical interventions to achieve weight loss are available, and there are data supporting their efficacy in obese patients. Combinations of agents may improve weight loss, improve tolerability, or minimize or even counteract the adverse events. Unfortunately, the new obesity management guidelines published in 2013 have a gap in that they do not address the role of pharmacotherapy, even though we did. So there are some that are good for short-term use. There's phentermine. It's an FDA drug Schedule 4 noradrenergic that causes appetite suppression. And its common adverse effects are insomnia, heart rate elevation, dry mouth, dizziness, tremors, headache, taste alterations, diarrhea, constipation, I've got to take a breath here, vomiting, gastrointestinal distress, anxiety, and restlessness. Or in the auto industry, you'd say your mileage may differ. Phentermine is, however, the most widely prescribed weight loss drug in the United States, with more than 25 million prescriptions written between 2008 and 2011. Now, there are some long-term use drugs out there. Now, you're going to forgive me for mispronouncing some of these, so just correct me if I'm wrong. There's lorcaserin, orlistat, phentermine, topiramate, extended release. The average loss using these, about 9% of initial weight, with phentermine, topiramate ER over 1 year, versus about 3% of initial weight with orlistat and lorcaserin. Consistently higher proportion of patients achieved weight loss of greater than 5% of baseline weight with phentermine, topiramate ER at the recommended dose. Now, the long-term follow-up trials show 1 year weight loss is sustained at 2 years. Now, that's impressive. Or 4 years with orlistat for patients who stay on therapy. Lorcaserin and phentermine plus topiramate ER may increase the hypoglycemic risk when used with insulin secretagogues or insulin. So clinically speaking, let's talk about your experience with the treatment for obesity. How does the presence of concomitant type 2 diabetes mellitus affect your approach to obesity therapy? What do you think?
Well, I've just started using a lot of these meds. I've looked at the data, and I've gotten a little bit quite comfortable with the phentermine, topiramate extended release combination. I had a patient actually.
So I pronounced it right.
Yes,
I did okay.
You did well. But I had a patient this week that had started on it a little over a year ago, and she'd lost 45 pounds. Now, that's not always the norm, of course, but it does seem that you have responders and non-responders, and for those patients who don't respond in the first 90 days or so, you either adjust the dose or you discontinue and try other approaches. So, I think these are helpful adjuncts, to the whole issue of obesity, but again, we get back to the societal context and, all the other barriers out there that are...
But let me just put it out there. We've tried A, the test pilot thing. I've tried A, I've tried B, I've tried C. I'm hitting the ripcord here. What's so bad about a pill? What's so bad about a medication? If it works, I mean, your patient that you spoke about had a tremendous response, right? If you're not going to get people to control their intake, maybe you can help them.
Well, and I agree with you. The main issue that is bad about a pill is the cost of the pill. That's really what it comes down to.
But what's the cost of being obese?
Well, the cost is very much, but right now, if you need to pay $150 to $250 a month just for the pill, there are a lot of patients who cannot afford it, or insurance companies who cannot pay for that as well. Yes, Jeffrey?
Yeah. Sorry to interrupt. And it's the time value of money. And this is it drives me crazy, but this is how managed care thinks. It's like I'm going to invest in this millions of dollars to pay for phentermine in my population, and maybe 20 years from now I'm going to avoid something. And that's, again, clinically we understand that, but financially and actuarially and everything else, that's not how that's not.
If I may give you a personal story, I gave a talk once to a group of healthcare managers, one of whom had just taken statins, so it's not about weight loss. Statins off the formulary because they cost a lot. And I asked, but what about 5 years down the line, all those bypass surgeries and coronary care unit admissions? He says, I got to make my fourth quarter.
And this argument is no different than the statin argument. You're paying for something to prevent something down the road. Right. So I don't know what makes this category unique, but it's a carve out, and I think that's where I think more people would start covering these because we have more options now. But the challenge is it's got to be done in a coordinated effort because somebody does not want to be the first person to do it because it puts them at a competitive disadvantage.
And I'd like to also point out something very important. You show that phentermine by itself is the most prescribed drug. That's a short-acting drug. It's good for 3 months. That's what it's approved for. It's like a jump-started diet that people thought, and then after that, you don't need to take it anymore. And people, it's very inexpensive. They'll go to a doctor around the corner. They'll pay $5 a week, and they get a drug, you know, and they do that. But that's not a long-term approach. And where do we fail? We fail when we see guidelines that came out, the obesity guideline in 2013. They don't mention medications. Why? They were based in 2009 data that did not have medications available even. So now when we look at obesity as a disease, we manage it, let's say like diabetes, with chronic medications, and we will prescribe medication chronically. We can see that 10, 15, 20, 25 pounds weight loss can be sustained long term. We can look for that now at a better approach.
So let me put you on the spot.
I like to be on the spot.
I figured that. Are there any patient types where medication is a first-line option for weight management with or without lifestyle modification?
I don't buy without. Lifestyle modification has to be the mainstay of managing patients.
But haven't we shown that lifestyle modification is hard?
It's hard, but it still has to be the mainstay. Of course it's hard. It's hard to stop smoking. But we showed that as long as we, as clinicians, as physicians, told our patient to stop, twice as many of them did stop smoking. We should not allow our patients, we should not forgive our patients when they come and say, oh, yes, 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 we know how hard it is. No, we should keep hammering at them. As many medications I will have, as many surgeries I will have, I will not be able to fight gluttony if I will accept it.
But let me just turn this around. The import of the question was not ignore lifestyle, but is it worth simply saying we're going to start with a pill, we'll get the lifestyle, we'll work on it as best we can, but this pill works. Go right ahead.
Well, we can do it concomitantly, yeah. And I think there is another recommendation for management that came out from the American Association of Clinical Endocrinologists, and we call it a complication-centric focus on managing people with obesity. So not everybody with obesity is sick. There's the fat and fit group, 15, 20%, doesn't matter. And then we assess how much complicated is the patient. The patient does not have a lot of comorbidities. Starting just with lifestyle makes sense. But if the patient has already some complications, then you want to give lifestyle with medical therapy. You may then find, that patient who is so very sick, hardly breathes, can't walk, sugars is high, medication galore, blood pressure doesn't stop, 3 stents last month, they may need to have directly surgery. So you base your patient where they are, and that's how you manage them.
Let me see if I'm getting the message here. You treat patients as, individuals?
Yeah. Oh, yeah. Oh, sorry. Yes.
Oh, my gosh. How does that go with public policy?